Hi, this is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. We have a very interesting topic today, but before we begin, I'd like to do a little bit of housekeeping. I'd like to give very, very much thanks to our supporters and sponsors, and they include Peak Technologies, the DHIN, which is the Delaware Health Information Network, Platinum Dining Group, Source Pass, and WSFS. The opinions in our podcast do not reflect the Medical Society of Delaware's endorsement of any product. It is strictly for informational and educational purposes only. And lastly, any questions, concerns, or suggestions for future podcasts can be directed to our website, healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. And we will be happy to answer any of your questions, concerns, or any of your suggestions.
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto, your host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Today we have a very interesting guest, Dr. Damian McHugh. We are going to talk about how to solve the American and British medical system so that it works better and more efficiently. Right, Dr. McHugh?
That's entirely correct, Nick. And after that, fix world poverty. We'll stop the wars. We'll do a great job today. I look forward to engaging your listeners and doing that with you, sir.
All right, a little bit about the bio on Dr. McHugh. Dr. McHugh grew up in Northern England. He attended med school at the Victoria University of Manchester, and since graduation, he has had a successful career as an ER physician. He is a member of the Royal College of General Practitioners after he had initial focus on primary care. He then went into practice as an ER doctor full-time after training at the University of North Carolina Hospital at Chapel Hill, and finally in partnership with UNC-REX Hospital in Raleigh, North Carolina, where he practiced emergency medicine for 21 years. He's always been a patient advocate. As he assumed greater responsibility roles and leadership roles, not only did he remain a patient advocate, he developed a passion for physician advocacy. He served a 3-year term on the North Carolina Medical Board and recently elected to the North Carolina Institute of Medicine. He recently retired after 31 years of practicing medicine. However, he has maintained his American Board of Emergency Medicine. He now has time for another passion of his, golf, and he also finds time spending with his dear wife Marion and his 2 sons Connor and Bradley. Welcome, Dr. McHugh. Okay, Damian, let's start out with the discussion of the difference that you perceive between the British and the American medical system. Tell me a little bit about that from your perspective.
I'll be glad to. Over the years that I've been in practice, I've been repeatedly asked, "Hey, Doc, which is the best system?" Mm-hmm. And I said, you know what? There's no answer to that question. The system that is the best depends on whose shoes you are wearing. I've had the privilege of looking after leaders of Fortune 500 companies, athletes, the governor's family, but I've also had that same privilege of looking after folks that have come from the homeless shelter in the ER seizing. And depending on whether or not one has health insurance, depending on whether or not one has a primary care doctor, the access to care and the resulting provision of care can be very difficult. Very different, and the contrasts across the east and west sides of the Atlantic are really stark and quite numerous.
Okay. We have, as you know, an insurance-driven system in our country. You have a single payer, correct?
In Britain, there is still a single payer, and that single payer is Her Majesty's government. I think you and I had referenced in some of our prep, Nick, that there's a wonderful book by T.R. Reid called The Healing of America, I'll tell the listeners that it was published pre-Obamacare, but in essence, Mr. Reed, who's a very eloquent author, goes around the world because he's living in various places, and he encounters different health systems, and he writes about the different doctors that looked after his chronic shoulder problem. One of the things that he does make a point of is the United Kingdom system, which is a single-payer system. And as is very different from our system here in America, pretty much doctors at the same level of training get the same pay, whether they be in Edinburgh, London, Birmingham, or Manchester.
Interesting.
It's a system that is funded by taxation at source, and there is no such thing as an insurance company. And would you believe, you can ask somebody in Britain, how many folks suffer from medical bankruptcy each year in this country? And they look at you bemused. They have no understanding of the concept of medical bankruptcy in England.
Not here in America. We do have medical bankruptcy as a common problem in this country. So,
up 65% of bankruptcies cite medical debt as a major factor.
Yes, I agree. But in Britain, you mentioned when we had our earlier discussions that there's access to care is a problem. Can you explain that? In Britain, that is.
It is. Access to care is a problem in both countries, and I would just ask the listener to conjure up their most favourite restaurant in the middle of their favourite city when thousands of others know the high-quality food and they all want to go there when they're hungry. So as such, restaurants will take reservations, and you know that if you don't have a reservation, just like Disney, you can't walk into the building. Unfortunately, we can't apply those same factors to healthcare. We can do it with airplanes, we can do it with Greyhound buses, but we can't do it with healthcare. The two systems have many things in common, and unfortunately access to care and burnout in the providers are two very prominent issues.
Okay. Now, we mentioned that at birth in Britain, you're assigned a doctor, correct?
That is true. You're assigned a national insurance number, which is your social, and then along with that national insurance number, you're given a general practitioner, not a pediatrician, a GP.
So the GPs are really overwhelmed with the degree of patient population that they have. So the ERs in Britain are overwhelmed because most people who are sick can't see their doctor for a while, end up in the ER. Is that correct?
It's true enough, Nick, and it's true for both countries. Again, think back to that restaurant analogy. There's a whole load of hungry people, and their hunger is not just to get their blood pressure checked or to get their heavy menstrual bleeding stopped. Their hunger is to try to get a diagnosis of this great big mass in the abdomen, which turns out to be pancreatic cancer. And because of the way we are living, and because of the fact that science is extending life, the demand for healthcare in both countries outstrips the need. We talked before about the provision of doctors to the population, and I looked up some Commonwealth Fund data from based on World Health Organization data, albeit 2017. It was interesting to me to see that we have 2.6 physicians per 1,000 people. I thought that we would have less in the UK, but it's actually more. There are 2.8 doctors per 1,000 folks in the UK. So to all intents and purposes, the ratio of us to our patients is essentially the same.
Well, it seems that Norway and Sweden have higher ones, don't they? They have 4.1 and 4.7, respectively, doctors per 1,000 patients. It's interesting. You sent me that, so I'm going to take that cheat sheet and work with it.
They do. And you know, when you look at the Commonwealth Fund's report, which is entitled Mirror Mirror, published in the fall of 2024, and I'd encourage all docs to go take a look at it. They compared our beguiled American healthcare system with the healthcare systems of 10 other quote civilized countries, including the UK, including Canada, and including many of those European and Nordic countries that you referenced. What they concluded was startling.
Mm-hmm.
We spend more than twice as much per capita. When you look at GDP ratios, we spend more than twice as much on healthcare as these other nations. But the best we could do in any index of morbidity and mortality was 12th. And oftentimes we were 18th or 20th.
I think we're 38. I think America, we're up in the 30s.
it depends on which data you look at, Nick. It depends on how carefully you scrutinize it. But the bottom line is we are spending large swaths of money in this healthcare system, and that money is neither going directly to benefit patients, nor is it going to reward the hard-working providers that are looking after them. It's going to the middlemen. It's going to PBMs. It's going to United Healthcare. It's just not being put at the right point where it needs to be put to work.
PBMs, would you define that for our non-medical personnel? Or listeners?
The polite way to describe PBMs is a pharmacy benefit manager, but many other physicians who are more educated and eloquent than me have described PBMs in many other ways. Essentially, a PBM is a middleman that comes between their patient, the patient, their doctor, and the third party that is paying for the drugs. Mm-hmm. And that PBM is involved intricately in that relationship. I understand, like many good ideas, the instigating idea was to insert them to reduce costs, but unfortunately they become very expensive fat men and women in the middle.
Mm-hmm. Well, all of this in both countries has led to a significant physician burnout. Now, America's 50% have said, doctors, that they've burn out sometime or other in their career, whereas in Britain it's worse, you say. 36,000 shortage of doctors in 2026 is another statistic that's going up here in America. That's our shortage of doctors, 36,000. So that means some people are just not becoming doctors because they don't want the hassle. Is that correct? Or is there other reasons leading to that besides ER docs who are burnt out for good reason? Here in America, in my younger years, I practiced, I am a solo practitioner. I would see 40 or 50 people a day in my office. And I also had another thing that I did, which was I was the medical director of a wound care and hyperbaric center for Christiana Care, our big hospital system. I had no life. I then subsequently came to understand the concept of concierge medicine, where you could take care of a limited amount of people for a significant a significant payment from a company that helps you run that, which in turn means that I had to say goodbye to a ton of patients, but I have given the 450 or 500 patients that I still have the best care that they can possibly get in every way, shape, or form. And it keeps me doing what I like to do and what I'm still good at. I was thinking of retiring at 65 because it was just getting too much. I had no life. I was exhausted at the end of the day. I don't know how I kept it up. I'm 75 now and I'm still working, but I'm doing what I like, making house calls, talking to the patients, seeing them, giving them good time, etc. But that limits the amount of patients I can see, because you don't want to take a lot on, because then you're back in the same rut that you were in before. And it's a great system, but too bad everybody can't have that kind of a doctor that takes care of them. So the burnout is an issue. Talk to me about some of the symptoms of a doctor burnout besides what I might have just mentioned.
Sure, I'm glad to. This is an area, Nick, where not only have I walked my own crippling journey, mm-hmm. I have seen others walk that same journey, and regrettably, as my specialist knowledge in this area improves and I engage more deeply statewide and nationally, I'm aware of more and more physicians who have taken suicide as the only way out. The way out from a grueling clinical practice, the way out from a deposition that they have either just delivered or were facing tomorrow, the way out from an adverse judgment in court. And the fact that the CDC suggests somewhere around one doctor a day takes their life by suicide, which leaves about 1 million patients without access to physicians each year. Those figures are unacceptable and they're startling. When we all went to medical school, Nick, very few of us went to make millions of dollars. Mm-hmm. Very few of us went to get a name like Elon Musk or to go and conquer Mars. We went to understand and to be part of the joy of service. we went to reach out a hand of service and friendship to others. We wanted to train ourselves both mentally and procedure-wise to be able to help humanity. And unfortunately, what has happened in this broken medical system is the joy of providing medical care has been eroded. Physicians, nurse practitioners, nurses, they all lament the fact that because of checkbox medicine has become commoditized. And their precious, precious time where they could listen to, where they could touch, where they could diagnose, prescribe, and reassure, that time's been eroded at the expense of checking boxes and meeting audit statistics. And as insurers continue to reduce the payments to doctors and to other healthcare providers, they feel that this hedonic treadmill that they're on is not only going faster and faster, but the slope is getting greater and greater, and they just can't keep up. And when they fall flat on their face, that is burnout, that is moral injury, that is mental crisis or suicide. And fortunately, with leadership from folks like the AMA and the Lorna Breen Foundation, we have realized in the last 10 years that when these canaries fall over, it's not due to weakness in the canaries, it's due to the toxicity of the coal mines.
Right, interesting. Do you see any better system in the world? Do you see any better system or how it could work better? More doctors obviously needed, but is there any system that would work smoothly and less driven by regulation?
In general, again, I hark back to T.R. Reid's book, The Healing of America. When Reid concludes that many of the European countries have a, quote, better healthcare system, what he really means is that the most good is being done for the most number of patients, and a majority of the physicians go to work feeling good about the care that they provide. Now, obviously, nobody can measure that in greenbacks or objective numbers, but you know as well as I do, as a physician, that if you have had a good shift at work, that shift may have embraced looking after a patient that was raped. That shift may have embraced follow-up of a patient with a terminal cancer. But when you have done your best, when you have applied your skills, and you have come alongside your patient as a healer, as a helper, as a friend, then you hold your head up proud when you leave your office. Mm-hmm. When the antithesis of all those things arrives, you leave the office burned out, fried, pissed off, and just not wanting to go back tomorrow. And that emotional exhaustion, that cynicism, that feeling of inefficacy, I just don't make a difference anymore, those are the hallmarks of burnout.
Yes,
and as we see with a typical iceberg, the iceberg that caused the Titanic to sink, only 8% of the iceberg is visible above the water. The vast majority, the hard, cold, painful part is below the water. Mm-hmm. And when we see our colleagues looking sharp, when we see them looking frustrated, in the past we've labeled them as a disruptive physician. I believe that it is more kind to say that's probably a burnt out physician, and the system is just too oppressive.
Yes. I've done a previous podcast on physician burnout and physician suicide, and I also discussed why we are so poor in developmental countries for outcomes when we have the best of everything in America. And my opinion on that issue was our lifestyle. Our lifestyle has become what you would call overindulgent. We eat too much, we smoke too much, we drink too much, and we do drugs. And that is probably what you see a lot in the emergency room as a result of a patient who doesn't take care of themselves. Is that true?
That's very true, Nick. On the more taxing and slightly more callous days in the ER, I've heard people say, thank God for stupidity, and without drugs, alcohol, and tobacco, we'd be out of business. That's clearly an uncharitable view. And you know, what I would say about the points you raise is, we certainly have, as patients, all of us have our part to play in our joint success with our neighbors, with our physicians, with the healthcare system that we all engage. And accountability and responsibility are unfortunately two factors which tend to be lacking in modern day society. I think also that one of the reasons for this great tirade of illness and the reason why America places 12th or 24th or 30th is we have something that the Australians have described as the inverse care law. And what that suggests is for people who've got ready access to care, read the American Insured. Think of CEOs of companies who pop off to the Mayo Clinic for 3 days for a $10,000 evaluation that includes a scan of your brain, an ultrasound of your aorta, a stress test, even though you didn't have any symptoms. But you'll get all those things, as well as a barrage of lab tests and a serum rhubarb and a test on your urine. You'll get all of that. And of course, it's going to generate abnormalities, because when you plot that curve of lab values, there's going to be 2.5% at the high end and 2.5% at the low end. So this is a sort of a rather trite example of the inverse care law, where people that have access to care and good health insurance become overutilizers. Think about the last NFL game you saw where somebody tore their ACL. You learned that the next morning in the press because that athlete went straight to the hospital, had an MRI, it was read by a radiologist and an orthopedic surgeon, and it was announced to the world the next day they had a torn ACL. You know for sure that if you and I were playing pickleball, that wouldn't happen to you or I. Mm-hmm. And also, if you're one of my patients at Healing Transitions, you have a seizure and you bend your knee around the chair, you're never going to see your MRI.
Right. Very good. Interesting. I think right now we could take a little break. And anyone who has any questions, comments, or even some suggestions for future podcasts, please reach us at our email, healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. We'll be back.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, coming back from the break, I gave a little thought, and we had a brief discussion about, obviously, physician burnout, and how do we cope with that situation? How do we help physicians? How do we make them able to deal with physician burnout or lack of, in your opinion?
That's a great point, Nick. That's really the million-dollar question. For any of your listeners that have listened in to my dear friend Dyke Drummond, who is the Happy MD, Dyke explains that burnout is not a problem. He says that the math question, what's 2 + 2, is a problem because that's got a discrete answer, 4. But there is no true solution to this dilemma of burnout because it's so multifactorial and because there are so many problematic features in these coal mines that we all have to work in each day. One thing that I tell, especially medical students and residents, is, let's let go of this myth that we are all supermen and superwomen. In years gone by, when we would proudly work 70, 80, 90 hours a week, it was wrong to show any cracks, to show any vulnerabilities. I do believe that there is great value in the sacred shared space of the doctor's office where only doctors are going to sit and talk. I believe there's great value in having honest, supportive conversations and just saying, hey, you know what, I heard you sort of raising your voice a little bit at that patient, and that was a little bit atypical for you. Are you doing okay? Dr. Jerry Hickson at Vanderbilt calls this the coffee cup conversation, where you just let another colleague know that you care about them and you've noticed that they're under stress a little bit.
You have supportive care with the other docs.
Right. And expanding outwards from that if you create a culture in your practice whereby it's okay to talk in private with another physician about these things that matter, if you choose to have a quiet dinner in a quiet room in a restaurant and just talk about the stresses and strains of practice, then these things are good. Before I left my last job with the major malpractice company that I worked for, I used to spend time regularly with physicians and just let them lead the conversation. If they wanted to talk about the pressures of medical board actions, great, that's where we would go, without talking about the specifics of a case. If they wanted to talk about the threat of lawsuits, again, without talking about the specific facts of a case, that's where we would go. And I would explain to them that if they have a good carrier, that carrier should be providing some psychological support in parallel with the defense of their medical board case or their suit. Hospital systems, if you look at Christiana Care right there on your doorstep, Christiana Care has got a great reputation in the physician wellness community for standing up its own program and for offering it to its healthcare workers. There's a Novant system down here in the Carolinas and also the University of North Carolina at Chapel Hill. These systems have really, really good, honest, viable programs where a doctor can go and quietly knock on the door and say, you know what, I'm struggling here. I don't need my supervisor to know. I don't need the chairman of the department to know, but I am struggling with the weight of medical practice.
Okay.
And in those systems, I know that there are good people that are good-hearted, that want patients to be safe and want doctors to continue with a fulfilling career.
Good. It's a good thing. I hope that becomes a nationwide and hopefully worldwide process so that doctors have someone to vent, someone to help them get over their probable depression and burnout. Here we are.
The other thing that I want to say before we move on, I absolutely applaud Dr. Joe Jordan and Dr. Clark Gaither at the North Carolina Professionals Health Plan. And I use the word Professionals Health Plan. This is the body in Raleigh that looks after physicians, pharmacists, veterinarians, anybody that has access to drugs. And in the past, our profession looked on these guys as, oh, those are the ones that help out the drunks and the druggies. But it couldn't be further from the truth. They are a committed body of professionals, and they have the expertise to assess and refer burned out practitioners, and you are talking to one right now. They did that for me in 2014, and it was life-saving. And I know they continue to do it, and they continue to save lives. To the best of my knowledge, there is a similar body in most other states. Mm-hmm. And if any of the listenership wants to check on that, they can look into the website for the Federation of State Professional Health Plans. And the CMO there is Dr. Chris Bundy, and Chris is a pioneer in this space. And he basically shares my goal of making sure that if we are given the privilege of looking after patients, we need to be healthy so that we can keep them healthy. And I will tell you for sure that each PHP works closely with the state medical board, and most of the state medical boards are set up with majorities of physicians, and those physicians recognize an ailing, unsafe colleague, and they will bring the guillotine down and pull the license if that's appropriate. However, I sense that most progressive medical boards, and North Carolina is one, they will try and support the physician if that physician is 101% committed to their own well-being and the safety of their patients.
I fully agree. I think that's a way to do it. This also should be subject to confidentiality for the physician that is presenting himself or herself, so that there are certain things that they can't infringe upon to utilize that in a way to take away a license without good cause.
That's true, and I would also encourage listeners to look at the Safe Haven program. Melina Davis and her team at the Medical Society of Virginia, they are the national leaders in this area, and they and their advocacy teams have pressed on the Virginia legislature to favorably change the statute such that physicians can be supported and edified if they are taking the many necessary measures to protect their mental health, their physical health, so that they can safely and diligently look after their patients. And Virginia is absolutely the leader in this sphere, in my humble opinion. It's closely followed by North Carolina, by Nevada, by Wyoming, and there is just more good work being done in this area, again, with the focus on safety of the patient.
Very good. Well, we're in a capitalistic society, as you know. So we really do not, as physicians, have control of our own profession. That is for sure. We have lots of regulation, and that contributes to burnout. Prior authorizations, you didn't dot the I, you didn't cross the T, you didn't do this right, you didn't do that right. You know, I had one of my insurers call me on my phone at 8 o'clock at night, my office phone, to see if I accepted calls for the patients that are in their particular practice, their particular companies. I thought that was really not a good process, but they got through to me. I gave them, I'm on call 24/7. I said, they get through just like you did. And are you happy with this? I hope so. And I hung up. I said, it just irked the hell out of me that happened. But it happens. I had a little bit of a crazy idea, being capitalistic and the power that an insurance company has with lobbyists, etc. How do we keep the capitalistic attitude and yet make it possibly a one-party payer system? You say, okay, how you do that? The government subsidizes the money to 4 insurance companies that are the biggest in the country. And they give them a section of our country, the East, the Central, the Mountain, and the Pacific. And one company takes each section, is given a certain amount of money to treat the patients, depending upon the per capita that they have in that section of the country. And in so doing, it's a one-party payer, a certain amount of money. That's it. You answer to one insurance company about everything, and not 4 or 5, even up to 10 insurance companies that may exist. So, is this an attitude that could possibly work? Who knows? Nobody's looked at it. Nobody's talked about it. But it would also incorporate an idea that restriction of care has to be given somewhere along the line, i.e., that's why they have prior authorizations. They force you not to pursue it, and they say, well, we don't give you the right to have that test for the patient. Why? I proved that the patient needs that test. Why can't it be done? And they don't necessarily always have a good reason. Or they want more information and this and that. And by the time the physician says, hell with it, I'll tell the patient we just can't get it approved. So I don't do that myself. I find that pretty neglectful to do so. So I pursue it until I get what I want, hopefully. A lot of docs
Nick,
have told.
Let me chip in. Let me chip in, because I'm gonna help you step down from the soapbox that we both stand on, because I feel so very strongly about this. My LinkedIn page will say that I'm a pathologically proud American, and indeed I am. I tell people that ask me that question, which is the best system? I say, hey, look, I vote with my feet. I choose to be here in North Carolina, not in Manchester. The healthcare system that I've been privileged to work in here in North Carolina has been second to none. I've been able to tap into expertise at UNC, Duke, Wake Forest, ECU, Atrium. These are some of the best medical minds in the world, and they've looked after my loved ones, my friends, my neighbors. So don't get me wrong, I vote with my feet, and I'm here. As somebody who in my grayer years has had more time and more energy to engage as a citizen, not in any of the jobs that I've worked, but I've engaged as a caring citizen with politicians, I took it upon myself to read a couple of books. I would encourage any of the engaged listeners to pick up the academic tome, which is written by Paul Starr, called The Social Transformation of American Medicine. The subtitle is The Rise of a Sovereign Profession and the Making of a Vast Industry. Starr won the Pulitzer Prize for this, and this is quoted in many academic studies of our healthcare system. And basically, he starts the historical look back at where insurance companies came from. And employers wanted to insure their workers such that when they got sick, the workers workers wouldn't be evicted from their homes, and the workers' families would have food. And that was where insurance for sickness first came in. And what Starr does in this probably 3-inch thick tome is he goes through and explains how insurance came to be. And then since the Second World War right through to the current day, he explains how insurance came to be morphed into what it is. We know it's not perfect, and I do tend to agree with Dr. Greg Murphy, who is the only practicing surgeon in Congress who, when he interviewed the CEOs of major insurers about 4 weeks ago in Congress, and this is on video, I share the opinion with Greg that if it were up to me, he would turn them to dust. Would get rid of for-profit insurers, and although I don't know his exact policy, I suspect he would want to replace it with insurers with their full power of capitalism, and those insurers, as you alluded, would be given a quarter slice of the cake, and they will be asked to provide the greatest care for the greatest number, given that the cake has a finite size.
Nice.
Again, there are lots of hungry people, and everybody needs to get a few morsels of food. The more recent book that I would again advocate to the readership is Troy N. Brennan's Transformation of American Health Insurance. Now, I don't wish to get political here, but he talks about the possibility of getting us on a path to Medicare for all. Now, I know that some of the listeners just had a conniption when I used those words, Medicare for all. So instead, what I'd like to say is getting us towards a unified payer system.
Agreed.
Similar to the National Health Service, where there is a finite amount of money that the government sets to provide health care. And as you alluded to earlier, that will, by necessity, involve some degree of rationing. It will need some good body of pharmacists looking at the drug utilization profiles. And there is a great body at Oxford, and they basically advise the NHS on whether or not the overall risk-benefit and cost ratio of drugs in the NHS are favourable. And the breadth of drugs that are available to British doctors is very, very different to the breadth of drugs that are available to American doctors. And that's one reason why the Brits only spend 9.6% of their GDP on healthcare, whereas the Americans spend closer to 20.
Wow. That's something to chew on. Well, you told me you worked ER all those years.
Yes, sir.
And your ERs were packed, crowded, I'm sure, all the time. Patients couldn't see their primary care doctor for a sore throat, so they sat in the ER for 4 hours waiting for you to deal with all the emergent situations before you could see them. Now, I have a story of a patient of mine who came off an airplane and couldn't clear his ears and got a little bit of vertigo. He went to the emergency room without calling me. He went to the emergency room, and by the time he left that emergency room, he had a $60,000 bill. He came to me in the office, and he said, and they gave me a decongestant, Doc. I said, I would have probably done that without you getting a $60,000 bill. But he had an MRI, he had this, he had that, and by the time his bill was there, it was near $60,000. So they were doing something called cover your butt type of thing, if you know what I mean. Okay, CYA. To avoid that sort of Damocles hanging over your head called malpractice, I think. I would say that would be it, because any good logical person who said you came off an airplane now, you can't, have a little vertigo, your ears are plugged up, you haven't equilibrized the inner ear to the external ear, why would they proceed in this direction? Any other reason other than to cover their butts against a malpractice suit?
I think that those three letters, Nick, CYA, those are really the answer. I mean, I've had the privilege of practicing for 8 years in the UK. I had the privilege of learning this craft in the UK, and I was really only minimally aware of that sort of Damocles hanging over me in Manchester and London. By contrast, as I started my second residency with Judy Tintinelli at Chapel Hill, again, I was being taught by some of the greatest emergency medical minds. Jim Manning and John Marks had hands in my career, and still what came through was no matter what you do, there is always going to be somebody like John Edwards or someone from the plaintiff's bar who'll be willing to come and second guess your work, especially if there was a bad clinical outcome, and especially if that outcome was sympathetic. And this is why, from my earliest career, I've been interested in the drivers of medical malpractice. And again, I felt very privileged to work full-time for a major malpractice company for 4 years. And in that time, I spent all of my time talking to the physician owners of that company and talking to other physicians, talking to prospects from this company about their journeys through their lawsuits and their medical board investigations. Now, I have to reiterate, I never ever would talk to a physician about the facts of their case. That's prohibited. That is something that has to happen with the attorney in their room. So I never ever did that. But I talked about trends, I talked about pressures, and I fed back to my company the extra things that we could do to help those physicians. In that journey, I learned that CYA medicine costs us somewhere around $4.5 to $5 billion per year. That's with a B, billion. And that is testing. Nick, that is radiation that I've exposed your brain to because you came into my ER with a headache and dizziness. And as a man who's over 40, I thought, gosh, I need to make sure I'm going to get sued. So I know that especially in those poor drunk patients who would come in from the community with yet another seizure, they got an automatic head CT. And I knew that for every 250 head CTs, I am responsible for causing a neoplasm. And that doesn't feel good. But to be able to calm the John Edwards on my shoulder, I reluctantly hit the button and said, yes, order the head CT. And you know that you can give an educated guess as a physician when your CT is going to be positive.
I agree. If you do a good neurological exam, you can tell where the lesion is. But that's not enough. If we do a good neurological exam, it's a subtle change, but we don't see it, we don't feel it, it doesn't come out in the exam, and we don't do the CT scan that is suggested for that, we subject to something we don't like. And that's, malpractice is not just a money thing, it's a personal thing. I think docs that do get sued feel badly about it and wonder it just plays on them. And I'm sure that adds to burnout also, as everything else might. Let's talk about something else.
Sure.
Recently in this area, our big hospital system, Christiana Care, had developed a program established by doctors to unionize. And according to the rules in America, to unionize, you have to be a hired doctor in a system. I, as a private doctor on the street, in private practice, I can't unionize, but they can. Is this a good idea? What's your thoughts on this?
Goodness me, I'm glad you asked me this, because when I last spent time with some of Delaware's most capable and caring physicians, I had the privilege of meeting the current and the future president of your system, and they both shared with me lots of helpful pointers towards my education of the pros and cons of unionization. I've been interested in my reading since to find out why this is such an interest in your part of the world. And in that broader reading, I've also come to learn that this is especially an interest amongst physicians in training in places like New York and California. When I think back to my history days, learning about the Industrial Revolution in Great Britain, when I learned about that in high school, it struck me that coal miners and guys and girls that worked in cotton mills, they weren't terribly well protected by their unscrupulous employers. And I think unionization came about not only so that they could have collective bargaining, but basically so their lives could be saved in the workplace. When you play the tape forward and you look at what's happened to some of our most prized workers, when you think of nurses, when you think of teachers, paramedics, coal miners again. You think of how they've unionized, and sure, there's always strength in numbers, but I think as they have formed unions, they may have gotten better pay packages, better benefits, but I'm aware of some who feel that there's been a commensurate erosion in their professionalism. And right now, as we accede to the fact that medicine has become commoditized, there's a part of me that worries if unionization is taken on more widely, will that continue to erode the professionalism that doctors have proudly held to this point? I just don't know, Nick.
I agree with you on everything you just said about unionization. And the end-all, be-all of unionization, in my opinion, is if you don't get what you want, you strike. And that is generally not in the wheelhouse of any doctor I know. We take an oath not to do something like that. What would happen to all the people who were being cared for if a group of doctors went on strike? So I don't see a future for unionization that it will be an effective unionization. Now, if you're unionizing to help people, in other words, a lot of our ER docs say, we're overwhelmed, people aren't being seen, they can't be seen, this, that, and the other thing. Maybe there's a better way through unionization to force the administration of a big system to make a better system. That would not lead to striking, but that is a good purpose for the purpose of the patient versus the doctor. Mm-hmm. Wow, this has been a very, very good very, very good discussion. Now, a little bit about malpractice. I know you have an interest in that.
Sure.
We know we need that insurance. There's no doubt about it, because if we didn't, we could be devastated and our lives could be ruined if we have lost a malpractice suit. Knock wood, I've not been sued, thank God, and I hope I never am. And all doctors feel the same. And I think they take, the ones that do get sued, take it very personally and lose some sleep over it, no doubt. Is it too restrictive? Is it too, I don't even know how to put the words to it. Does it force us to do things we don't want to do just to cover our butts? What do you think? I guess it is, but is there a solution? Is there anything else that can be done?
Nick, I think what you're asking me is a twofold question. I think you're asking, hey, Damian, is the American tort system broken? And if it is, why and what can we do to fix it? I had the great privilege of being hosted for golf by Governor Jeb Bush down in Florida, maybe about 3 months ago.
Lucky you.
Yeah, the governor is a wonderful man. And again, I would emphasize to all listeners, I'm a pathologically proud American and a registered independent. And I have proudly voted on both sides of the aisle. And I very proudly greeted John McCain in the Senate dining room before I ate my Navy bean soup. He said, "Thank you for those kind comments, sir. I wish you well in your career." And I was very proud to have my youngest son stand there, and afterwards he saw the tears in my eyes as I told him I had just shook the hand of a true American hero. Mm-hmm. Jeb Bush did a lot of wonderful work advocating staunchly for doctors in Florida in the early 2000s, and he signed into law, he signed into law things that protected doctors, things that edified doctors to go and practice with confidence, with compassion, with sensitivity for the benefit of the population of Florida. Unfortunately, later on in years, the Florida Supreme Court overturned his good work. But in essence, no doctor would ever want for a patient to have no recourse if that physician's drunkenness or that physician's negligence had truly harmed a patient.
Agreed.
You know that as well as I do, Nick.
Agreed.
However, and this is my own humble opinion, the opinion of Damian McHugh, I believe that 8 to 8.5 of lawsuits that are filed in America are without merit, and that is not synonymous with frivolous, but those suits, in my opinion, are without merit. What I mean by that is I would absolutely concede there was a bad outcome. However, that outcome was a direct result of bad trauma or bad disease, and categorically not bad doctoring. And this is a concept that our tort system fails to bring out. We have all these many lawsuits each year, and the only real correlates are the payouts in these lawsuits. they tend to correlate with a bad and sympathetic outcome. They don't correlate with the actual presence or absence of malpractice. And again, because the devil is in the details, and the answer is always in following the Benjamins, we see that in recent years in our country, the frequency of paid lawsuits is actually going down. However, the severity of those lawsuits is massively increasing. Right. The United States Chamber of Commerce terms a nuclear verdict in a tort case as a verdict in excess of 10 million. Now they brought in this term thermonuclear verdict, meaning a verdict in excess of 100 million.
Wow.
And what it's important for doctors to understand, if you remember back to your basic renal physiology, in order to get calciphylaxis, in order to get calcium precipitating in your tissues, you had to look at the cross product of calcium and phosphorus. And nowadays, the total cost of malpractice is akin to that, because it's the cross product of frequency and severity. And sure, frequency is going down, but severity is going through the roof, Nick.
Oh, wow. Well, this has been a very interesting discussion. I know we talked last night about you're an emergency room doctor for many years.
Yes, sir.
Do you watch The Pit? And you said no. I really enjoy The Pit, but I worked part time in an ER trying to make it when I was first starting out. Sure. But The Pit seems to me to be very realistic and very educational, and it talks about the administrative problems that they have, the fact that the administration wants them to turn those beds over quickly as possible, etc. And you said to me, I said to you actually, it's like you said you don't watch it, and I said it's like the shoemaker's son has no shoes. So right. The ER doctor really isn't interested in the ER stuff on the television, right?
Well,
you got to watch The Pit.
Well, this brings me to Dr. Jerome Adams, who used to talk about work-life integration. And I know that some of my ER colleagues, they love to watch The Pit, and indeed many of them have been privileged to act as advisors. And I do send a shout out to Noah Wiley and the production team, because they have not only put a lot of thoughtful preparation into their product, but they have become advocates for emergency care workers.
Yes, they have.
And when I hear that Chris Bundy at the FSPHP was consulted because they wanted to portray an ER physician with substance abuse problems, I can only applaud that they went to the highest authority in the land to understand how to best do that. Likewise, when one of their staff was getting sued, they went to Geeta Pensa, who's probably the most prolific litigation expert, also a fellow emergency physician, and she advised them about how that should play out. So I think the content is wonderful. However, for me, Nick, I prefer to go and lose golf balls. I prefer to go and watch the Carolina Hurricanes pace the team that's in town like they did last night. So I'm not a fan of The Pit, but I do have applause and kudos to that team that have advanced the hard work of emergency care doctors so much.
Well, that's good that you hit the ball, and I hope you hit them straight. Now, before we end, you mentioned the book by Brennan and Starr. Could you give us the titles of Troy Brennan's book first?
Pleasure. Troy N. Brennan. It's the transformation of American health insurance on the path to Medicare for all. And again, listeners should know that Troy was a Harvard Chan School of Public Health professor. He's a professor of medicine. He's an internal medicine doc.
Okay.
He was a CMO at CVS Health. In my readings in the last 2 to 3 years, I have come to really respect and realize his authority and his deep knowledge. So I really do, encourage folks to read his book, and I don't get any money if you buy a copy of his book.
Gotcha.
Same for Paul Starr, Starr, The Social Transformation of American Medicine. Together, Nick, those two books have they fueled my knowledge to learn more about how we ended up in this situation. And the thing that I'm learning from the most now is an organization called Physicians for a National Health Plan, PNHP. And my dear friend, Dr. Brian Bramson, who is an infectious disease professor at UNC, he has taught me a whole lot about what it means to have Medicare for All legislation in Congress since 2024. I've told him that, in general, with my experience as the leader of an ER group, I'd be much more comfortable if this were TRICARE for all. I think the military insurance and the military system, whereby the military system looks after its doctors, where it pays those doctors a whole lot more than Medicare, and where it essentially puts a bottleneck on whether or not a patient can bring a suit. I think that system is even more attractive to me than Medicare for all.
Interesting.
Yeah, Dr. Brennan's a proponent of Medicare Advantage for all, but we know that unfortunately some of our for-profit insurers have learned where the loopholes are to wriggle through Medicare Advantage, such that whilst it's financially advantageous for them, it's disadvantageous for their poor elderly patients.
Interesting.
So more about that in the future.
Very good. Well, Dr. Damian McHugh has given us a great discussion today. I've enjoyed it tremendously. I'm sure our audience will also. Did you ever think of writing a book yourself?
No, sir, I don't have enough time because I spend so much time in the woods looking for golf balls, but I've also learned to make that time therapeutic. What I do want to do is I want to take every opportunity through avenues like this to motivate and to fuel other physicians to stand up, to learn about how we got to where we're at, but more importantly to link arms and to fight back with passion and purpose so that we can continue joyful medical practice and so that we can continue to serve our patients, which is the reason why we put ourselves through all those years of study and all that considerable debt to simply give back to humanity.
Very good. This has been a wonderful conversation, and I appreciate you joining us for it. And thank you for being here. This is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Again, I will give you an email that you can correspond with us if you have any questions, concerns, or even topics for future programs by going to our email healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. Till next time, this is Dr. Biasotto.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitton. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.